Yeah, so my talk was really focused on this challenge, really, which is, can we develop precision therapeutics for mesothelioma? It's a cancer that presents certain challenges, and I started by really talking about the challenge itself, which is that this is a cancer that is really full of tumor suppressor mutations, these certain type of cancer gene alterations which haven't traditionally been drugged in cancer before. They represent a very substantial bit of the cancer genome, but have yet to be successfully drugged. So that's the first challenge, is that we're dealing with a new type of pharmacology. There are some notable examples, BRCA1, for example, and PARP inhibitors. And indeed, that's something we're exploring within mesothelioma. But the approach we need to take when dealing with mesothelioma is synthetic lethality. It's trying to identify a vulnerability that emerges when you have a loss of function in a key gene. So we have a very, very good idea of what the genes that are altered now within mesothelioma are. And I then went on to really talk about how we're trying to target these genes. We've seen single-arm phase 2 studies, which have shown, I think, perhaps the most important findings have been that we can do it. We can pre-select patients based on basically their molecular makeup. And these have included BAP1, CDKN2A, and most recently, actually, we're beginning to see NF2 selected trials coming through. I presented some data from examples, and we published, for example, last year, the use of the CDK4/6 inhibitor in the context of patients with 9p deletion. This was a trial that I think that in a very aggressive form of mesothelioma, one with a very short survival time and a very short time to progression, was associated with the vast majority of patients having some shrinkage in their tumor, and indeed some patients having partial responses. So we're actually now sequencing these patients and trying to understand precisely why they respond at all, even though we did this pre-selection with a protein called P16-INK4A. We found that we could actually enrich for responders better if we looked at a protein called MTAP. And MTAP seems to mirror much better the genomic alteration in the gene of interest. Okay, so when we look at MTAP, we see a very high frequency of deletion if MTAP is negative. And that may be go some way to explaining why it was a better predictive marker. Sorry, I'll say that again. So that's why MTAP was a better predictive marker of sensitivity, I think, to CDK4/6. And we see that recapitulated in the lab as well. We then sort of went on to talk about some of the new types of drugs which are coming through. Aztecs have a phase 1 trial at the moment, which is open, and this is targeting MDM2 in mesothelioma. And the story here is that mesotheliomas have predominantly P53 wild type. So these drugs can activate P53. MDM2 releases P53. And certainly this is something we're quite excited to see, because these drugs, again, represent a new class of tumor suppressor targeting agent, but designed for P53 wild-type cancers, of which mesothelioma represents quite a sort of a small group, representation of the small group. Of the big three, then, the last of these is BAP1. And last year, we published with Marjorie Zador as first author, an EZH2 inhibitor study, tazemetostat. And this is a trial that actually was used in patients who had BAP1 alterations. The protein levels were either non-nuclear or loss of expression. And in those patients, around about half of those, the study met its primary endpoint, about half of those patients had some disease control. We, in our practice, actually saw some very dramatic reductions in tumor volume happening over several months. Excellent, partial response, but the process behind what was driving that response is still quite unclear. We believe the immune system may be playing into sensitivity, but the precise mechanisms of sensitivity and why a patient responds or doesn't when they're both BAP1 negative is still unclear. There are a number of other emerging targets. We've, in the past, had a case report showing that if a patient has a mutation in the hedgehog pathway, such as PATH1 loss, we see that in about 6% of patients. they are sensitive to an inhibitor of what is known as smoothend. This is a so-called synthetic lethal interaction. We can see it in basal cell carcinomas, actually, where these drugs have been used and are licensed. But in mesothelioma, if that mutation is present at low frequency, then that could be an opportunity to treat with this type of drug. And so the last bit of my talk was really focusing on how do we aim to encompass all this diversity, this sort of inter-patient heterogeneity. How do we, work with that in a clinical setting? And of course, the way is to develop what we call umbrella studies. And umbrella studies will allow us to perhaps sequence or to get a panel of markers before the patient's ever treated, and then essentially siphon those patients with a particular marker into a particular treatment arm. That's what we did with the MIST trial, which was the first of these types of trial in mesothelioma. And we've completed 5 arms of that study. And we're seeing some very interesting outcomes. We're seeing, for example, I mentioned the abemaciclib can achieve a partial response. The goal now with these types of studies is to really drill into the genomics of these patients' tumors and try to fully understand why these patients respond at all. And it's on that basis that we can then develop the next generation of maybe randomized studies with the hope of maybe bringing precision medicine to the clinic. That sort of is a brief overview, I think, of what I talked about, if I remember correctly.